Hello. Okay, I think we're live.
Yeah.
Yeah. So, welcome everybody to first in the series of our Instagram lives for Fertility Awareness Week. My name's Amy Barrie, and I'm the lab manager at Care Chester and Care Liverpool, and I'm joined by...
I'm Victoria Sephton. I'm the medical director here at Care Chester. I'm the deputy medical director at Care Liverpool.
So we're on for half an hour, and we're hoping to cover quite a lot, as much as we can. We've had a few questions beforehand, and we'll keep an eye on questions as we're going through. But the title of this evening's Instagram live is Optimising Fertility Treatments. So we're going to go through a few of the additional treatments that we would offer at Care for optimising your fertility treatment. But first of all, we just wanted to say a quick thing about it being Fertility Awareness Week. Obviously, we all know that fertility affects 1 in 6 couples, and that equates to around 3.5 million people in the UK. So anyone tuning in, certainly not alone. And Fertility Awareness Week is all about changing perceptions, raising awareness, and signposting support. So we're hopefully going to do a bit of that tonight for you. And through the week, we've got a number of Instagram lives set up. So on Tuesday, tomorrow, we've got one all about egg donation. So that's going to be with Julie and Lisa, who are from our Central Egg Bank team. On Wednesday, it's going to be with Professor Charles Kingsland and Zita West, and they're going to be talking about fitness and nutrition. On Thursday, we've got the medical director from Birmingham, Rima, and she's going to be talking about polycystic ovaries. And then on Friday, we've got the virtual patient event, which you would need to register for if you were interested. But that will basically take you through the IVF journey from start to finish, and talk in a little bit more detail about certain things that Care can offer, in terms of funding and support, and that kind of thing, not just treatments. So worth saying that you can get in touch at any time. You can go to a website, you can find information about your local care clinic on our Care Fertility website, and there's also a general inquiries number that you can call, which is 0800 564 2270 if you wanted to. So, I think we'll make a start.
Yeah.
So, the first question we had...
Yeah. Was what we would recommend, if there's any tests that we would recommend for couples that have had 3 failed cycles of treatment. So, from that, we've taken that you've had 3 failed embryo transfers. And I think what we have to do is we have to think about the 2 different elements that are important in achieving a pregnancy. There are your embryos, and there are where we are putting those embryos. So we've got to consider the womb and the lining of the womb, that's called the endometrium, and also consider the quality of the embryos. So when you've had 3 failed embryo transfers of what we would assess as good quality embryos, you become or fall into a group that we refer to as recurrent implantation failure, and that's if you've not achieved a positive pregnancy test at all. And in this group of patients, we often know that there are more tests that we need to explore to look at what's going on with the embryos and what's going on with the endometrium at that time of implantation. And for the past over 2 years now, we've been offering a test called an ERA and an endometrio test. And that test is assessing the lining of the womb at the time of when we would be expecting to return an embryo and put an embryo in the endometrium. And it involves you having a very straightforward biopsy of the lining of the womb at a very particular timed point in your cycle using medication. So we set you up as if you're having an embryo transfer, and instead of putting the embryo in, we take a small biopsy of the lining of the womb out. And that sample of the lining of the womb is then assessed to see if you have what's called a normal window of receptivity, and if the receptors in the lining of your womb that are switched on and improve your chance of implantation, if they are switched on at the correct time. Now, we know in most women it should be around 123 hours after you've started progesterone, or a certain amount of time from when you had your LH surge, usually within 6 days. So we know that that sample is then assessed to see, do you have that normal window of receptivity, or is yours displaced compared to what we would accept as a normal window? And often we have women who have a receptive window that's at 140 hours or 150 hours. And so we know that if we were to put an embryo back in at 123, that embryo is never going to implant, because the receptors on the lining of the womb are not switched on and they're not ready to receive that embryo. So that's a really important part of the testing we can offer. That on that same biopsy that we take out, that can also be then assessed for what's called the endometrial microbiome. So you probably know that in your gut, in your intestine, you have good bacteria and bacteria that can potentially cause you to have a stomach upset. And we know that the same kind of environment happens in the lining of the womb. You have protective bacteria, and you can have pathogenic bacteria that cause chronic inflammation in the lining of the womb. And it's about the balance of that protective bacteria, and if there's any presence of pathogenic bacteria, that we test on that same biopsy. And very often we'll get a report that says there's a displaced window, and there's an abnormal microbiome, and there's possibly pathogenic bacteria that are causing chronic inflammation. So, and we can then work to fix those and bring the microbiome back in line. So for your gut health, you can take drinks like Yakult and things that promote the lactobacilli, the positive, favourable bacteria that help. And it's the same for when you have, if that particular lactobacilli is reduced in the lining of the womb, we can give vaginal probiotics to replace and replenish that protective and that favourable bacteria. And we know that in women who have had recurrent pregnancy loss, often close to 60% of women who've had recurrent miscarriage have a depleted lactobacilli. So this test is not just for couples potentially going through IVF treatment and replacing embryos, but it's also really important in women who've had recurrent pregnancy loss as well. And there's a big multi-centre national trial going on at the moment called the SPERM trial, looking at the links with chronic endometritis and taking antibiotics to help improve pregnancy outcomes in recurrent miscarriage. So that's just one of the tests that we can offer in terms of looking at recurrent implantation failure, that a simple biopsy taken at exactly the right time, we can tell, is your lining receptive when we want it to be? You will get a personalised embryo transfer window, and we will also know, have you got the right level of protective and favourable bacteria for implantation, or are there any pathogenic bacteria that we need to clear? And sometimes we have to retest once you've had antibiotics and probiotics to check that we've got the balance right. So they're really important tests that we can definitely offer. The other things that we offer for recurrent implantation failure, again, looking at the host side of things rather than the embryo, is to look at a test called Care Unity. Now, this is looking at a gene mutation, and I don't want to get too detailed, but it's a gene mutation that's carried on chromosome 4, and that's responsible for making a very critical protein that is important at that early stage of implantation and is important throughout the whole of pregnancy. So the sperm or the egg, so the male or the female in the relationship who are having treatment, can actually carry that gene mutation. And if either one carries that gene mutation, that can be transmitted into the embryo. And that can then cause either recurrent implantation failure or early pregnancy loss. It can also cause growth restriction in later pregnancy and later placental problems. So a lot of this work was done by our founder, Simon Fishel, and this test has been available for just over 18 months through CARE, and we're affiliated with a lab in the US that does this testing for us. It's a very simple test. It involves a swab of the inside of your mouth to collect your DNA, and then we can see if either of you carry that gene mutation. And if you do, we know that from studies that have been performed that if you give you a daily injection of heparin or clexane, a low molecular weight heparin, from the time of your embryo transfer, and that's maintained through your pregnancy, then we can improve live birth outcomes. So that's really another test that we've got that we really use a lot in women where they're having either recurrent loss or recurrent implantation failure.
So a couple of questions came through while you were talking about that. So is the receptivity assay test offered as a routine test?
So it can be at the outset of your treatment. If you think that you want to know that at the very start of your treatment, before you create any embryos at all, then that is an option. You can do that then. So far to date, we've reserved it, or we offer it when we've already had 1 or 2 failures, so that it's there as a separate part of testing, but you can actually have it at any stage of your treatment. And in clinics across the US, they tend to do it at the very outset of the treatment, so that they've got their personalised window and they know that the microbiome levels are correct.
Yeah. And it's worth saying that isn't a test that's funded by the NHS, unfortunately.
No, it's not.
Which is why we don't tend to offer it just to anyone. We offer it to a subset of patients that we think it's going to be really useful for.
But that's not to say that patients who are coming through for NHS treatment, a lot of CCGs will allow you to have that because it's an investigation. But obviously you'd have to check with your local guidelines where you've got your funding, and then in this area here in Chester, all of our local CCGs allow those testing, different investigations to be added into that pathway. Does the receptive window stay the same month to month? So this is a really interesting question, because we just had a meeting with the experts in this just last week, and we asked that question, and they said that the window does stay the same, and is reliably stays the same because they've done repeat testing. The only time where it might change is if you've had a major intervention or insult, maybe even if you've had a pregnancy or a miscarriage, or you've carried a pregnancy to full term, and then you've come back for more treatment and you want to recheck that your window is the same. But they've given us the assurance that in patients going through treatment, it pretty much stays the same. You don't have to retest it every cycle.
Yeah, good. So we've covered the host and the endometrium, and now the other part of it that we want to try and optimise is the embryo. So we want to try and make sure we're getting you, we are picking the best embryo possible. So the best scenario to be in is that we're putting back a chromosomally normal day 5 potentially blastocyst into a receptivity tested endometrium. So that's the goal.
Yeah.
So for getting the embryo, we obviously the ideal is to make sure that it's chromosomally normal, and we do that by doing a process called pre-implantation genetic testing for aneuploidy, and lots of people will have heard of this, so PGTA, and it involves taking away sort of 5 or 6 cells from the embryo when it's got over 100, and we send these cells away for testing at a genetics lab, and that lab will tell us if those 5 cells have got the right number of chromosomes in or not. And that is supposed to represent the entire embryo, so that we know when we get those results, if the 5 cells that we sent away have got the right number of chromosomes, then the likelihood is the embryo also has the right number of chromosomes as a whole. And we would term that embryo as normal or euploid. So it's a good idea to have PGTA for it's again a certain subset of patients. We wouldn't recommend it necessarily for everyone, but it's really good for reducing the time to pregnancy. So if you're likely to get a good number of embryos, we want to be able to pick out of those embryos which ones are normal and which ones aren't, so that you don't go through multiple embryo transfers of potentially abnormal embryos. The other thing that we have at Care is something called Care Maps, and this is what we would call non-invasive. So it isn't, we don't take any cells away from the embryo, we leave the embryo completely untouched, and that's the beauty of Care Maps. So the embryo stays in the incubator for the whole 5 days, and there's a camera inside the incubator that takes a picture of the embryo every 5 to 10 minutes. And using the data that these images generate, we give the embryo a score, and that score is from 1 to 10. 1's the worst, 10's the best. And we can give you, based on that score, the chance of a live birth, the chance of having a baby from that embryo. And it means that we, as embryologists, can pick out of a group of potentially 10 embryos, the best embryo out of the bunch, to make sure that we're giving you the best chance as soon as possible. So the Care Map software was built on tens of thousands of embryos data that we know have created babies. So we have this data from embryos that we know have created pregnancies and live births, and we've used it to generate a model to tell us which embryos also fit that pattern. So both, again, not funded by the NHS, but can be added on to treatment if you fit the criteria and if we think it will be beneficial for you. And all of these things would be talked about at a consultation with you, to talk about which of these offerings that we have would be most beneficial. So
I can just see a question there about PGTA. Would it potentially put the embryos at risk?
Yeah, so there is a small chance of risk to the embryos. Obviously, it's what we would call an invasive test, so we are removing cells from the embryo, but the survival rate is very good. It's a less than 5% chance that an embryo would be damaged, but yes, there is a small risk. Yeah.
I think there's nothing with zero risk.
Exactly.
But it is extremely small.
Yeah.
Okay.
So, the one thing that often gets overlooked, we talk a lot about the woman and the environment, and we talk a lot about the embryo, but we don't necessarily talk a lot about the man or the sperm provider. And we have done a few Instagrams on male infertility already, so we're not going to talk loads about it, but in terms of optimising fertility treatment, I think it's important to talk about two tests that we offer, the SOS test and then the Zymot. So can you tell us a bit about the SOS?
Yeah, so the SOS really is looking at whether the sperm and the seminal fluid has any potentially damaging oxidative stress levels within that sample. So if, for instance, you do a semen analysis and we see there's a slightly low motility or a lower than expected morphology, which is the way the sperm actually look, and whether the head of the sperm looks normal or the tail of the sperm looks normal, if those come back with slightly suboptimal parameters, then there is a chance that what is causing that is that the sperm is undergoing oxidative stress. And the oxidative stress, if it's in very high levels, can be linked to poor sperm function and also cell DNA damage, so that when that sperm then enters the egg to make the embryo, you may then get poor embryo development or no embryo development at all. And we know that within our normal diet, we should be having lots of antioxidants if you have a good healthy diet, and that will hopefully control the free radicals that cause the oxidative stress. But other things can increase the free radicals more than the antioxidants that we get from our diets. Things like smoking, increased alcohol intake, potentially high saturated fats in our diet, and also aging and higher BMI or increased weight. So we know that if we can make some changes to lifestyle, we can improve the risk of oxidative stress on the sperm, but that's not always the whole answer. And so there is an SOS test that we can do, a sperm oxidative stress test, that is really simple and can be done at the same time as when you have your semen analysis, although it would have an extra fee on top for the SOS test. And we know that if that comes back as raised, we can give you high dose antioxidants that can hopefully again bring that oxidative reductive potential back into normal balance as to where it should be, so that we've optimized the sperm and improved the chance then of embryo development. Now it takes 60 to 90 days for the spermatogenesis cycle for a sperm cell to become a mature sperm that would be in a sample that you would produce. So if we were to do the SOS test and find that there was oxidative stress occurring, then you would have to have the antioxidants for that 60 to 90 days and then a retest to check that it had worked. So sometimes, that people feel, that might delay my treatment. And yes, it might, but it's about optimizing and trying to fix something that we may have seen possibly in a previous cycle, or we've got indications from your very first semen analysis that this would be a good option to look at from the outset.
So there's some questions coming through about it's a bit of a
it's a balance.
Yeah. Yeah. So we've got some patients who have been told their sperm isn't stressed enough.
Okay. so they're in reductive potential.
Yeah.
Okay.
So I think what's really important about the SOS test, and there's some questions coming through about why isn't this just offered to everyone? Those who are trying to conceive naturally, and it is a very good point. I think men can go away and take a lot of antioxidants and think that they're doing a really good job. But actually, if you haven't got any oxidative stress and you take antioxidants, it can push you into something called reductive stress, which is as damaging. So it's really important to make sure that you take antioxidants on recommendation. It's not good to just take them because you think you're doing a good job. It's not really like vitamins, like multivitamins, taking a multivitamin a day. So having the SOS test, if you're trying to get pregnant naturally, would be potentially a good idea. But it's not. You can't get it on the NHS. It is you have to fund that, unfortunately.
And another area again where we know that this can be important, and one of the important tests is a lot of couples that I look after who have had recurrent pregnancy loss and recurrent miscarriage. We over investigate the female side of things, and yet this is a really key test that we can do for men, because if their partner's had 2 or more losses, we could be looking at this situation with the sperm, because it then causes potentially abnormal DNA to enter the embryo, and that can then cause a pregnancy loss. So it's really important that it's a test that we offer for couples where they've had recurrent loss, men who are over 40, if you've got higher BMI, and again if you've got suboptimal results on your initial semen analysis, and if you're smoking or have a high alcohol intake, all of which you'll probably already be optimizing. But it's about understanding the impact that those can have, and then the improvements that you can have when you actually make those lifestyle changes.
And as you said earlier, it is really easy. It can be done at the same time as a semen analysis. And we've had a question about how quickly the results come back. Well, they're instant, the SOS results. The lab knows straight away what that result is. It's just a case of getting you back in to talk about those results and talk about where you go from there, really. So then if you have a raised oxidative stress level, so a raised SOS result, as you said, we would recommend antioxidants for a course of 2 to 3 months, ideally 3 months, and then we'd retest to make sure that had normalised. And then if you were coming through for treatment, we could offer something called Zymot, which is this sperm selection method.
So I think when I talk to couples about we're trying to optimise everything, we've looked at the sperm, we've done the antioxidants, and now we know that Zymot has been launched across care for the last since July time, but it was piloted for 12 months before that to try and make sure that the device was safe to use. And it's essentially a sperm preparation device that's a cell membrane filter that the sperm have to swim through or make it to the other side to then be used, and that's the sample that would then be used to potentially then do ICSI to inseminate eggs. So it's almost the sperm selecting themselves, and we know that often within that little micro sample, those sperm are the ones that will have the least DNA fragmentation and the ones that have been under the least oxidative stress, if it still exists.
Yeah, hopefully the ones that are most competent
will get through
fertilising.
Yeah.
So in terms of the SOS, we've had a question about whether it can be done on surgically retrieved sperm. So this would be testicular retrieved sperm. Unfortunately not. The concentration, the number of sperm in the sample needs to be a certain level, and you just don't get that number with testicular surgically retrieved sperm, so unfortunately not. I can see a couple of people are saying they've added it onto their cycle, which is good, so hopefully, fingers crossed.
And I know that since we've been using it, you've been seeing really nice embryo quality, so it's so far we're really pleased with the results that we're getting across the group. Good.
So a couple of other questions that have just come through. People are asking lots of questions now about optimising their own treatment. So we'll try and go through a couple of those in the last couple of minutes. So a patient, her husband or partner has had an azeospermic sample. What can they do about that? So I guess that your question is, is there anything possibly that can be done? And of course I'm sure there could be. You just need to make sure that you are seeing the right person, the right consultant, and asking the right questions. So there might be that there's a blockage, and in which case we can surgically retrieve sperm. It might be that there's a genetic cause for it. Again, we might be able to surgically retrieve sperm. There's definitely places to go if there's been an azeospermic sample. Yeah.
But it needs further investigation under a fertility consultant with a special interest in andrology, which is the equivalent of gynecology for women. Andrology is for men, it's about your reproductive health, and so that way to be able to run the tests to find out, is it a blockage or is it a production problem, and then they would know what's the best way to help you in terms of accessing and surgically retrieving sperm.
And then we've had a question about embryo development. So the eggs were collected, ICSI was performed, but there was no embryo development. So I assume that can be one of two things. There's been no fertilisation at all, or there has been fertilisation, but then the embryos have arrested. So in the case of the first one, potentially one thing you could look at is something called artificial egg activation. And that's really not used that often, and you would need some really good information about that from your doctor, and really good counselling about the pros and cons for you to make a decision about whether it's worthwhile. But when there's what we would call a failed fertilisation following ICSI, there's not an awful lot more that you can do. It's likely that there's a potential what we would call an activation problem. So the eggs or the sperm aren't just managing to do that fertilisation process properly. If there was fertilisation but there was failed embryo development, there are a few things that potentially you could do, but one thing that we do here is we have a multidisciplinary clinical review meeting. So we pick up these patients who have these poor outcomes and we go through everything with a fine-tooth comb and make sure that we're optimising absolutely everything. So the dosage of the drugs, the day of the egg collection, what type of trigger was taken, and we'd look at lots of different things to try and optimise. But I guess from picking anything, failed embryo development, I'm not sure what you would suggest really.
I mean, often we do an SOS to see, don't we, if there's because we know that the egg's kind of in charge of the initial 48 hours of development, and then the sperm becomes more important in the egg and the sperm continuing to activate each other and enhance that further development. So if development is starting to decline from day 3 onwards, we would then look at more specifically the SOS test for the sperm to see if that is adding into or causing some part of the embryo not to continue with good development. And that's where we use that sometimes as well. Even if the sperm parameters have seemed completely fine, that's where we'd use that test again to look at that if that's a factor for the embryo development.
Yeah. A question about even if you tested an embryo with PGTA and it came back as normal, could it still fail? Absolutely yes. That's never 100%. And it's all about optimising. So we know we've got a normal embryo, we know we're putting it back in the right environment, but there's still loads that has to happen for that implantation and that pregnancy process to take place properly.
And in normal conception, you know, for couples that don't have any known fertility problems, in any one menstrual cycle, the natural ability to create a pregnancy that goes to a live birth is around 35 to 40% maximum. So we're not good reproducers as a species. And so what we're trying to do with assisted conception is to put you at least at normal and hopefully beyond, at least at what we would expect and hopefully beyond. So even when we have what we call a euploid normal embryo, sometimes that's just still will not work, even if we're putting it into the right environment at the right time, because it's not 100%, unfortunately.
Yeah. And then the last questions from someone called Hopeful Mama. They're freaking out because they've got their appointment tomorrow and they don't know what questions to ask. So I just wanted to say, just write everything down. I don't know that there's a rule book for what you should and shouldn't ask, but just try and write everything down. Don't worry, everyone freaks out, and hopefully it all goes okay.
Yeah, and really, you know, often the doctor or the clinician will say, have you got any questions, and you go blank. So maybe after this evening you've got some things that you can write down in advance, and then you can ask a few of these questions when you have your consult tomorrow.
Okay, so we've run a little bit over, but thanks everyone for joining. It's been really nice. Nice to see everyone logging on, and hopefully you all managed to tune in to the rest of the week's lineup. You can find all the information on the Instagram page, and like I say, go onto the website and have a look around there as well.
Yeah.
All right.
Okay.
See you soon.
Bye. Bye. Bye.